Good morning, colleagues. Welcome to the day two of the meeting. And before we start the technical session, I shall briefly summarize the day one deliberations. And as you are aware, we discussed two critical aspects of safe management of Vivax malaria, namely diagnosis and treatment. As regards diagnosis, it was highlighted that qualitative tests for G6PD test may not be a best option, and countries need to move to a quantitative test, especially before using tafenoquine for anti-relapse treatment. And the updates on various studies being conducted were also presented. The other aspect of diagnosis which was presented was serological testing and its use in different scenarios like high risk categories in elimination settings, screening in Plasmodium falciparum cases and migrants, and also monitoring and evaluation of programs. This is a new strategy which was presented. And while this can be very important tool, especially the places which are near elimination, but countries express the concern over sensitivity, specificity, and cost implications. So these are all the aspects which are under discussion, and we realize that lot of work needs to be done. And also context specific evidence need to be generated related to acceptability, training requirements, implementation, etc before these serological tests can be introduced and the new evidence is there to recommend the use for in different scenarios. Now, coming to the treatment part, a number of studies were presented, and including tafenoquine and its pediatric formulation, and also the feasibility studies. Some of the studies showed that, and also in Brazil, that tafenoquine can be correctly used at health facility, which is very encouraging. And now tafenoquine is registered in many countries, and in some countries, like in India, phase 3 studies are also planned, which will be a great development. And the other use has chemoprophylaxis and also the safety and efficacy of short course of high dose primaquine, which was recently recommended by WHO. These were also presented and discussed, the pros and cons and other aspects. And the another important issue which was presented was the universal radical cure, both in Plasmodium falciparum and Plasmodium vivax. It could be the same medicine to be used or different ones, but then because in P. falciparum cases, sometimes the relapses are more common. Relapses of P. vivax are more common. That is why this strategy was tested and results were presented. Of course, there are again challenges for this approach, which were also discussed, and maybe at country level they can be taken up. So now, today we start with the APMEN Vivax working group updates. And for this, I would request Dr. Phone to Sihan to moderate the session. And he is Associate Editor of APMEN, Associate Director of APMEN, and he has over 16 years of experience in public health and emergency operations with a variety of organizations. Over to you, Dr. Phone.
Yes, thank you very much, Dr. Nina. So we have three expert presentations lined up for our session on APMEN Vivax working group updates. So I would like to extend gratitude to Dr. Caroline Lash, Dr. Manish Shrestha, Dr. Zishan for their valuable time and willingness to share their insights and presentation. So this presentation will be delivered back to back and followed by Q&A session. So I would like to encourage our colleagues and partners to actively participate in Q&A session after three presentations. So by asking question directly to the speaker, or you can submit your question in Q&A box. So let's begin with our first presentation, focusing on update on APMEN Vivax working group activities, presented by Dr. Manish. So Dr. Manish has been serving as technical coordinator of the APMEN Vivax working group since 2021. He holds a PhD in Health Social Science and Master of Public Health from Mahidol University, Thailand. Before his involvement in Health Social Science, Dr. Manish was originally trained as a dental surgeon and worked in the field of community dentistry in Nepal. So in his previous role, he worked with the Malaria Consortium Asia and served as like a consultant for regional CSO meeting in Bangkok. So I would like to invite Dr. Manish to present.
Thank you, Dr. Phone, for that wonderful introduction. And let me kindly share my screen. I hope you can see the screen there.
Yes.
Like Dr. Nina mentioned, yesterday we heard about the emerging evidences and experiences. And you must have been wondering, what is the Vivax Working Group up to? Now, this is where I come in and tell you what we are exactly doing this term. But before that, I'd like to again reiterate that the Vivax Working Group is composed of Dr. Nina as chair for this term. We previously had our fantastic Dr. Kamal Azin, who chaired for the 2021-2022 term. We have Dr. Caroline Lynch. We call her Carrie. She's a co-chair, and myself as the technical coordinator. And this Vivax Working Group is hosted by MMV since 2021. But what is the goal of the Vivax Working Group? Our goal is to contribute towards uptake and implementation of better radical cure for Vivax malaria. Yesterday, you heard all about radical cure and different tools and different studies happening. But our focus, and you might ask us, what do we mean by better radical cure? Yesterday, you heard about radical cure, universal radical cure. By better radical cure, we mean that we better use the WHO recommended therapy and diagnostics, and also integrate the new tools and treatment as and when they're approved and recommended by WHO. So not only the improvement of current recommendation, but also integration of new tools as and when they're approved. So therefore, our focus has always been on catalyzing policy change and readying the health systems for policy changes when it changes. So those were our guiding mindset when we took over the APMEN Vivax Working Group. And then just to give you, before I let you highlight what we're doing for the 2023-2024 session, I'd like to just give you a quick recap of what we did in our last term. First of all, we had this prioritizing exercise wherein we collected the key priorities from different stakeholders through virtual workshops, through physical workshops, through virtual surveys, through even annual meetings, and where we identified the main priorities of national programs for Vivax elimination. And this has actually driven our work plan to progress for Vivax elimination in the region. And secondly, we went deep dive into the prioritization and also took on readiness planning activity in two countries, Pakistan and PNG, wherein Pakistan and PNG, that was the first time in both countries Vivax was being talked in the national program, and they made Vivax roadmaps after the activity. And in Pakistan, the roadmap actually got endorsed from all provinces, and now it is integrated in their national strategic plan. And in PNG, this was the first time the provincial stakeholders were talking about Vivax. And we also developed and piloted the options assessment toolkit. We had co-development partners with national programs from Afghanistan, Solomon Islands, and Vietnam, and we piloted that in our annual meeting last year. And in our learnings and sharing, we had two annual meetings. One was virtual, the other one was face-to-face back in 2022 in Thailand. And we also had regular tech talks, some on pharmacovigilance, one on patient adherence and implementation research. So overall, we had 4 tech talks in that term. And we also produced one evidence brief on patient adherence. In the meantime, we also produced 2 mini videos on our efforts on what APMEN Vivax was doing. We had 2 newsletters edited by Dr. Carey and Dr. Karma, and we also had several presentations outside. Now, coming back to 2023-24, now this has guided our work plan for this term. And I'll give you the work plan and what we're doing at the moment. Our first objective for this term is to proactively plan and troubleshoot for more effective implementation. Herein, we have, again, highlighted Pakistan where through the readiness planning, the outcome was that they needed this XPD pilot project. And this is what we're supporting in Pakistan through the APMEN and MMB funding. Dr. Jisan will talk more about this in his presentation shortly after. But to let you an update that the training for the pilot project is happening in December, and the test analyzers and test kits have already arrived in Islamabad, and hopefully the pilot project will go ahead smoothly. This project is where we are just pilot testing the GCPD testing so that the healthcare workers can get an early experience of using it and how to integrate it into the health system. And we'll document the early experiences, the challenges, and then this might be and how it can be scaled up. The second objective is to increase the quality of training and of trainers and healthcare workers. This came as one of the most priority in the last annual meeting and from the prioritization exercise, wherein national one programs identified that the quality of training needed to be better. And in this one, we are trying to have improved training materials for effective training and including experiential learning, and then also develop a guide as to how to train using those approaches for the trainers, and then implement and support the national programs to have this training materials, use these training materials in the training, in the routine trainings for Vivax and malaria in general. And then also advocate to programs to incorporate community initiatives, community monitoring, and even have an angle of gender education and so just see a perspective in those. So the update is that the training materials have been developed and they have been adapted into Thai language for use in Thailand in their trainings. And at the moment, these training materials are in process of being adapted to Urdu for use in the Pakistan context. So this is happening as we speak. And for our third objective is still on cross-regional learning and advocacy. And here we will organize annual meetings, country-to-country sessions, and at least 4 tech talks like we did last term, and also develop technical briefs, mostly on based on the peer-to-peer country sessions, for example, on health system support in Bhutan, when we highlight the integrated pharmacovigilance, the access strategies, where we highlight the early experiences from Solomon Islands, and health system support, where we highlight the targeted counseling as how that can improve patient adherence. So these are in process. This virtual meeting is actually the annual meeting that couldn't happen this year, so we're having it virtually. Next year, we're having a face-to-face annual meeting. The country-to-country sessions are planned for 2024. For the tech talks, for the 4 tech talks, we had 1 this term. We had a very successful tech talk on higher doses of primaquine, exploring its safety, which was conducted in September this year. And through the discussions and the outputs of that tech talk, we hope that the recommendations on higher doses of primaquine will have some impact on that one when the WHO recommendation will come out. And also the technical briefs will be developed after the country-to-country sessions are held in 2024. And our last objective is the evidence and data uptake and use, wherein we plan to formulate country peer-to-peer learning hubs, like I discussed in the last objective. For example, we plan to have a session between PNG and Bhutan, wherein they discuss their pharmacovigilance. This was actually identified by the PNG, our members in PNG, where they were very interested in learning about the integrated pharmacovigilance from Bhutan in our last annual meeting. So we are planning to have a session with them, hopefully early next year. And there's also been an increased interest in implementation of tafenoquine and chloroquine with GCPD in Laos, Cambodia, and Thailand. And we're trying to also hold country-to-country sessions with them, including Brazil. And then finally, we will also have a session with Cambodia and Solomon Islands on community activities, wherein they can see how to integrate the testing of G6PD through the community. So these are actually the 4 objectives that we have for this work plan, and this is the update that I have for the APMEN Vivax working group. If you have any questions, please feel free to write on the Q&A or ask me during the live Q&A session. Over to you, Dr. Phone. Thank you.
Thank you, Dr. Manish, for sharing the Vivax working group work plan and activities and the 4 objectives, so which include proactive planning for effective implementation, enhancing the quality of health worker training, cross-border collaboration, and technical advocacy. And the last one is an evidence and data update through peer-to-peer approaches. So here, congratulations to the Vivax working group that is member for this successful activities and approaches in 2023, and welcome the commitment and plan for 2024 activities. Thank you, Dr. Manish. So I saw the raise a hand from Sherry. So we have the question and answer session at the end of the 3 presentation. So yeah, could you please wait? So let's go to the next speaker. We have the recorded presentation from Dr. Mohammad Zishan Harun, who would discuss progress towards the virus elimination in Pakistan. Now, Dr. Zishan is an assistant professor at the Department of Community Medicine, Arab Medical College, Pakistan. He is a well-recognized consultant and serves as the case management expert at the Malaria Technical Working Group of the DOMC, the Directorate of Malaria Control in Pakistan. Dr. Zishan has been actively involved in APMEN Pakistan readiness planning activities and GCPD pilot project since 2021. So I would like to request Dr. Manish, could you please share the Dr. Zishan recording? Yeah.
Good morning and good afternoon, everyone. This is Dr. Mohammad Zishan Harun. I am member of the National Malaria Technical Working Group, and I'll be presenting progress towards Vivax elimination in Pakistan. Let me first apologize for not presenting this presentation live to all the audience. I had some last minute travel commitment, and unfortunately I cannot make it, so I'll be presenting this recorded video. Coming towards Malaria situation in Pakistan, I'll not indulge into the details. I hope Dr. Hamad gave you a brief outlook of malaria situation in Pakistan. But just to refresh your memory, malaria is a major public health challenge. Around 98% of population lives in the areas where there is a risk of getting malaria. In 2021, around 400,000 cases were reported across Pakistan, and most of these cases were Vivax malaria cases. In 2022, Pakistan was devastated by a flood, and that changed the epidemiology of malaria across the country. We saw an upsurge of falciparum cases. However, Vivax malaria dominated the overall numbers. Around 1.6 million cases were reported across Pakistan. This year, till 15th of October, around 1.8 million cases have been reported. So there's a huge surge in number of malaria cases in Pakistan this year. We believe that although we have intense transmission of malaria going on in various provinces, but we still think that a lot of these confirmed Vivax cases might be because of relapse. We know that during floods there were issues with procurement of Primaquine, there were stockouts, and there is and always has been issue with Primaquine compliance for 14 days Primaquine compliance. So a lot of patients, Vivax patients, they didn't take Primaquine, and that is the reason why we believe that a lot of these cases can be because of relapse of Vivax malaria. Coming back towards Vivax elimination, Pakistan has seen scaled up malaria intervention in the last few years, and we have seen increased willingness and commitment by the donors, by the partners and the government to control malaria in Pakistan. So this commitment and willingness has culminated in the form of malaria elimination strategy that Pakistan initiated on 25th April 2020. This elimination strategy was in line with global technical strategy. However, the national and provincial strategic plans, they are more focused on falciparum, and somehow Vivax specific strategies and interventions they were overlooked. Fortunately, during the same time period, Pakistan started collaborating with uh, APMEN Vivax working group, and we soon realized that to eliminate malaria in Pakistan, we need to focus on Vivax as well. We need to have Vivax specific strategies because of specific challenges that are posed by Vivax for its elimination. And it was decided to conduct readiness planning exercise. This decision was taken after multiple rounds of technical sessions and discussions between Directorate of Malaria Control, which is a national program, a malaria control program of Pakistan, and APMEN Vivax working group. So this readiness planning exercise was conducted in January of 2022, and the sole objective of this activity was to develop a Vivax elimination roadmap based on the gaps, risks, and issues identified by the national and provincial malaria control programs, the partners, the principal recipients, and the sub-recipients of Global Fund grants, academia, and other technical experts and partners that are working in malaria control and elimination in the country. These are some pictures of the workshop. We had provincial and national malaria control programs, academia, partners. It was a 2-day workshop. The participants gave their valuable inputs, their suggestions, and we had a very fruitful discussion on the issues and challenges that are specific to Vivax malaria and how we can prioritize and how we can develop certain strategies for elimination of Vivax in the country. Here you can see partners working in groups to identify risk and challenges. So at the end of the workshop, the part, all the participants, they realized that uh, radical cure with primaquine is basically not working. With this with this regimen of radical cure, we might not achieve Vivax elimination, and we have to think about and introduce new tools for radical cure of Vivax malaria. And specifically, everybody talked about tefenoquine, and everyone realized that suggested rather that if we are interested and serious in Vivax malaria elimination in Pakistan, we have to introduce tefenoquine somehow, when and if it is approved by WHO. Secondly, everyone suggested that we need to have strategies that are specific to Vivax elimination based on the unique challenges that is posed by Vivax malaria. And we have to identify stakeholders, whether national or international, and improve coordination and collaboration with these stakeholders so that we improve our readiness of Vivax elimination and we improve our understanding of Vivax elimination. So after the workshop, everybody started working on Vivax elimination, and Pakistan developed and endorsed its Vivax elimination roadmap, and this was basically endorsed by the national and provincial malaria control programs. This Vivax elimination roadmap was then incorporated into existing malaria elimination strategy. Uh, we are in process of having a tripartite MOU between Drug Regulatory Authority of Pakistan, a Directorate of Malaria Control, which is a national program, and USP. Directorate of Malaria Control and DRAP has a bilateral MOU for pharmacovigilance. We developed tefenoquine rollout plan for DRAP, which is mandated by DRAP for registration of tefenoquine. And the national program is continuous in contact in collaborating with WHO, Global Fund, and APMEN how to proceed further after this Vivax elimination roadmap, how we are going to conduct those activities or implement those strategies that are highlighted in the roadmap. So one of the things that as I told you earlier, that the most of the participants, they were of opinion that we have to introduce tefenoquine, but there is a catch with that because tafenoquine, for tafenoquine, you have to have a G6PD testing. So to get it in Pakistan, we don't have routine G6PD testing for the patients. We have very few centers across Pakistan, mostly in private setup, which do G6PD testing, and it costs a lot of money. So more than 99% of patients, they don't have access to G6PD testing. So the Directorate of Malaria Control was in continuous contact with all the partners on how to introduce G6PD, get to know how feasible it is for Pakistan to introduce G6PD testing and incorporate this G6PD testing in its routine Vivax malaria management. So after deliberation and after requesting APMEN and MMV, thankfully APMEN and MMV has agreed to support G6PD pilot project in Pakistan. The Directorate of Malaria Control, the Provincial Malaria Control Programs, the Aga Khan University and Drug Regulatory Authority of Pakistan, they are on board. And soon we will be launching this pilot project across 9 high malaria endemic districts. We will be targeting district headquarter hospitals, 3 district headquarter hospitals in Balochistan and Sindh, 2 in Khyber Pakhtunkhwa, and 1 district headquarter hospital in Punjab will be included in this pilot project. This is a map of Pakistan, and I've highlighted these 9 districts as in orange color in all 4 provinces of Pakistan. And we've selected these districts based on various factors, but one of the factor was to include as much as possible the different ethnicities of Pakistan. So I'll brief you on why we did that in next coming slide. So the main objective of this G6PD pilot project is to assess the operational feasibility of integrating G6PD testing into routine Vivax malaria case management. We will also be assessing healthcare's proficiency in the use of G6PD test, how well they can use a G6PD test, what are the barriers and facilitators for their use, and for the safe radical cure of Vivax malaria. We'll also try to explore the frequency of G6PD deficiency in various ethnicities of Pakistani population, and that is one of the reasons why we selected those 9 districts. In the past, in like late 80s and early 90s, there were certain studies conducted in Pakistan G6PD deficiency, but they were mostly conducted in Afghan population in refugee camps. So we have conflicting reports on the true prevalence of G6PD deficiency. So this study will again kind of validate the figures that have been generated over the past few decades on the prevalence of G6PD. So we'll get to know, we'll get some idea on the true prevalence of G6PD. This study will involve the patients that are diagnosed with Vivax, whether it's mixed or mono infection, and we will interview healthcare providers that are involved in Vivax case management. This is basically an implementation research that will test an implementation strategy and its related outcomes. This study will involve collection of the baseline data, then we'll introduce quantitative G6PD testing, and then we'll have midline endline data collection. This will be mostly qualitative interviews. We will conduct interviews of healthcare providers. We will also conduct interviews for the district health officers that are involved in the management of the health facilities, and we would also like to interview provincial program managers and national program manager on the feasibility of integrating G6PD testing in the routine malaria care. So the training of healthcare providers on use of G6PD is planned for first week of December, and soon after training, we will launch this pilot project in 9 districts in the second week of December, and then we'll have regular monitoring and troubleshooting visits to those 9 health facilities. The approximate duration of the project is 6 months. So the possible outcomes of this pilot project, we believe that this will be of benefit to both the patients and the health system. For the patients, at least for those that are coming to those selected healthcare facilities, will have the information about their G6PD status. this data will also inform us to change or to update our national treatment guidelines. For the health systems, I think this project will provide field experience on how G6PD testing can be integrated into routine malaria case management. We believe this pilot project will highlight challenges, issues, and facilitators that can support or hinder this integration into routine malaria case management. Secondly, the data that will be generated from this pilot project will provide us a tool to advocate to Global Fund, the national program, the provincial malaria control programs to incorporate and introduce G6PD testing. And eventually, once the G6PD testing is introduced and incorporated into routine malaria case management, when and if tafenoquine is approved by WHO, the integration of tafenoquine to routine radical cure of Vivax malaria will become very easy, and eventually this will be a way to malaria elimination in Pakistan. Thank you.
So thank you. Our gratitude to Dr. Vishan for sharing insight on the progress of Vivax elimination activity in Pakistan. So he emphasized the need for Vivax malaria elimination in Pakistan and the Vivax working group activities, which include readiness planning workshop and GCPD pilot project plan. Dr. Vishan also provided valuable insight into the outcome of the readiness planning workshop. So I noticed that one of them was the approval and endorsement of the elimination roadmap by both national and provincial malaria program. Additionally, the incorporation of this roadmap into existing national and provincial malaria elimination strategy by the DOMC is the significant great achievement of the Vivax working group. So finally, we have Dr. Caroline Lang, who will present on training top national program priority. Dr. Gary serves as an MNV regional advisor for the Greater Mekong sub-region, Indonesia, and PNG. With nearly 20 years of experience, she is a parasitologist and epidemiologist with expertise in malaria control, maternal health, and family planning programs across 30 countries. Dr. Carey holds a PhD in malaria epidemiology from the London School of Hygiene and Tropical Medicine and MSc in applied parasitology and medical entomology from the Liverpool School of Tropical Medicine. She has also worked as a consultant providing high-level technical advice to various organizations. So I would like to invite Dr. Carey to present. Yeah, so thank you.
Okay, thank you. Did some investigation on my background. Are my slides okay? They're viewable?
Yes, yes.
Yeah, great. Okay. So I'm going to talk today about training, which came up. We spoke about it last year in the face-to-face meeting. It came up as a top national program priority. And this is why we're coming back to it again this year, having discussed it in group work, just to give you an update as to what we're doing on training on Vivax Radical Cure. Let me figure out how to move this. There we go. So this is, again, and Manash mentioned this before, we did this prioritization exercise. And the reason we're coming back to high quality training for health workers is because, as you can see here, all stakeholders prioritized high quality training as something that was important to achieve Vivax malaria elimination and malaria elimination in general in the Asia Pacific region. Just to highlight and kind of as an aside, you'll see here quality stock data also came up as a priority. We also discussed that last year. And that's one of the reasons we have Dr. Sunil presenting later on pool procurement from the Global Fund side of things. That was based on the outputs from the group work. But coming back to the high quality training, this is why we're focusing on this area this year for our activities. So I wanted to just go into a bit more detail as to why we think this is so important. So once the national programs brought it up as an issue, and other stakeholders as well, we started to do a bit of a deep dive to better understand the status of training and how things are at. And this image that I'm showing is is where we're tracking new tools from the end of the research and development pipeline down through the hand of a patient who has malaria. So I'll ignore the first two processes, the global processes and the national processes for the moment. And I want to focus on national policy implementation, because as you can see with the arrow on effectiveness decay, from the point where a patient, say, is suffering from malaria and needs to get to a health facility, we begin to see a decrease in the effectiveness of that patient's ability to get treatment at the end of the day. So already, and bearing in mind, we've spoken a lot about malaria elimination. Already we know that on average, only around 70% of patients are getting access to where new tools or even current tools are available. When they get to a health facility, and this is a very stubborn figure of around 80%, around 80% of health facilities will have the stock of treatment or diagnostics to serve that patient effectively. And this is something, as I've said, it's a stubborn figure. We've seen it in papers from 2013 and even more recent research on this area. And then we come to the next part, which is the capacity of health workers. And here, again, it's a pretty stubborn statistic. We see pretty clearly in literature that only around 50% of health workers have the knowledge or have recently been trained on evidence-based treatment guidelines. And obviously, these figures are global averages, so I'm masking a lot of variation between countries. But when you look over time, the figures seem to kind of stick at around these points. If you put all of those together, what you end up with is a patient can sometimes is receiving maybe 30 to 70% effective treatment. And I think I'm talking about malaria in general. I think for Vivax specifically, it would be towards the lower end of that, as we've seen, for example, in work by Dr. Bipin, who's online here, and others in the Asia Pacific region. So then I want to come to why we're focusing in again on training. So the capacity of health workers is very much associated with whether a patient is effectively effectively receives good malaria case management. But I've put it in these dotted lines here to the availability of diagnostics and overall patient access, because I think a well-trained health worker also has an indirect impact on those other two areas. So by focusing in on better quality training, which the national programs picked up on, we can improve all of that or decrease all of that effectiveness decay, I think, along that pathway to a certain extent. And just to reiterate, we know from a lot of clinical studies that when a health worker complies to evidence-based national treatment protocols, patients receive high quality of care and there is effective coverage. So we know that that's possible. The gap is the translation from training to a health worker who's going to use those materials. So just to come back to that 50% figure of health facility staff trained in malaria case management, the training that we're talking about is in-service training. So we're talking about public health services where you've got nurses and doctors, pharmacists, medical technologists who have been working in the system for a while. We're not talking about private sector. And I go back to Dr. Zishan's presentation. We know, for example, in Pakistan, that perhaps 50% of patients will present at the private sector. So we're not even taking into account the private sector when we talk about this. We're just looking at public health services. And the training strategy that's been used for the last 20, maybe 30 years is cascade training. And you all, I'm sure, will be familiar with this in the public system, where at the national level, you have a set of trainers who are trained, and then they go down to the next level, maybe provincial or district level. They train another set of trainers, and then they go on to train health workers at the health facility level or from the health facility level. And you can already perhaps imagine that even in that cascade, you're losing some effectiveness in the training or quality of the training as that strategy is rolled out. Then I want to just look at, again, reiterating the importance of training, how much is invested in training. I couldn't find a firm figure on this, but we do know, I think between all of us, we could come up with a ballpark figure. We know that there's millions being spent on training each year. We do know, for example, in global fund grants, Bowser in 2014 was looking at the first 7 rounds only, and between 10 and 50% of those grants was spent on training. And those grants come up to the millions or tens of millions or hundreds of millions in some countries. We also know that PMI and USAID, for example, also put a huge amount into training every year and in the kind of training strategies that I've just described. And yet, there's not very much evidence that those training strategies are improving the performance and the quality of health workers. So a couple of systematic reviews have been done. Leslie et al. In 2016 and Rowe et al. Has done these huge systematic reviews, and they're finding maybe modest effects of the type of training that I've described on healthcare worker performance. So then the question is, what exactly are the issues that are coming up? And so between the APMEN work that we're doing and through the PAVE, which is the Partnership for Vivax Elimination work that we do here in the Greater Mekong subregion, we try to kind of think through, well, what are the issues? And we've been out to observe a few trainings in the region. And what we're seeing is that the training strategies, that cascade training, are pretty didactic. They're not very participatory. And I think the reason behind that is because there's a lot of time pressure on national programs, as you all know, to do an awful lot of things in a very limited amount of time. Time is a very, very precious resource, and there's a lot of competing priorities. And that, I think, results in defaulting back to the traditional didactic training, which kind of ends up being a bit of a briefing at the end of the day rather than a transfer of knowledge. I think we're also missing some key quality benchmarks that are needed. For example, competency testing. At the moment, often when trainings take place, the indicator is, did the training take place or how many people were trained, as opposed to what proportion of participants achieved over 85% in the post-training competency. So we need some quality benchmarks in for the training. And then also we're seeing health systems issues. So even when you've got very highly competent trainers and people who are trained well, there is a lot of health worker turnover and attrition. And then there's a knock-on effect of the ability to teach. I think part of that 50% of health worker problem is to do with the fact that, you know, when we bring health workers together for training, we typically get 1 or 2 people from a health facility, and that health facility could have 10 to 12 people who are seeing patients. So you're only training a proportion of the people in that facility. Obviously, this changes down the health system level, but I think that could have something to do with that. And so we're also not making sure actively that the people who are teaching, who are taught, are going on to teach others in the facilities. And this is something we discussed at length during the face-to-face meeting in 2022 in Bangkok. And here's just a couple of the things that you all as participants who were at that meeting came up with, is how can we improve the training? And one participant, for example, said that we need to do planning on how to do the actual training, what resources are required, and what preparedness. And from that group work, the suggestions that came out that we're now working on are having standard operating procedures for trainers. So those that includes, for example, what resources are required, how to prepare for training sessions. Also training trainers how to teach, or training other health workers how to teach. So teaching methodology, not just the technical aspects of malaria. The other suggestion was to have a database, even focused on trainers at the moment, of trainer competency and availability. The availability of competent trainers came up quite frequently in the group work that we did last year in Bangkok together. And then, as I mentioned before, some more granular performance indicators for training sessions. So not just whether people receive training or how many people receive training, but what was the impact of that training, and did we get knowledge transfer during that training? So what are we doing as the APMEN Vivax working group? What we've done is that we've had a set of generic training materials that were developed through the Partnership for Vivax Elimination. And we've taken those materials and we've tried to do exactly what you all suggested last year, and that's to put in teaching methods and participative methods into that training. We've also worked on standard operating procedures or manuals and notes for trainers. So a very specific set of how someone gets prepared for training. We've also set up some quality benchmarks, and we have competency tests available both for theory and for practice for the G6PD analyzers, and then mini scenarios for clinicians. And we're piloting those in 2 countries, in Thailand and also in Pakistan, which is kind of folded into the G6PD pilots that Dr. Zishan just described will be happening there. So all in all, I'll say that this training, it does slightly require a new mindset to achieve new results. And that's what we're trying to bring about. And that requires some behavior change as well in the minds of people who are organizing the training. I will say though, also out of the group work that we did last year, it became apparent that there are some technical advocacy needs as well for the national programs. Often participants during the meeting last year described the fact that improving quality of training is not highly prioritized throughout the health system. And this relates back to those competing priorities that I described earlier on, that national programs have so much on their plates to do that it's very difficult to prioritize training and to take the time needed to reflect and organize those trainings to those quality benchmarks. Within those group works, 12 participants describe low political will or governmental priorities as a challenge to ensuring quality training. The potential solutions that we've been discussing about that is raising that as a priority among key financing partners and within ministries of health. And then maybe a more, a kind of side way to do that is to think about outsourcing training. So where the national program retain the oversight and monitoring and the technical expertise, but the people who are doing the training are actually pedagogically trained. They're people whose bread and butter is training, and they know how to do adult learning and education to achieve post-competency training results that are acceptable. These are just some examples of the training materials. So as I mentioned, we've developed these facilitator standard operating procedures. These are very comprehensive notes related to sets of modular slides that we had previously developed. We've tried to include different teaching methods to increase knowledge transfer. So we're trying to teach people how to teach as well as give them the technical content. We are looking at ensuring training quality. So we have competency evaluations. PATH have these great competency evaluations that have been integrated into the generic training materials we developed previously. But we're now looking at kind of setting up standard Excel spreadsheets and data sets for how the training competency tests can be analyzed afterwards quite easily for national programs to see how participants are doing and where they have to focus perhaps supervision afterwards. And then, of course, we have sample agendas depending on who's being trained at what level of the health system. So I'll stop there and just refer you to the vivaxmalaria.org website. That's where the generic set of training materials are available at the moment. And as we pilot and test this revised set of materials, we'll also put them up on the website as well. And with that, I'll say thank you very much.
Thank you very much, Dr. Kerry, for your presentation, highlighting the critical importance of quality training of health workers to ensure compliance with treatment guidelines, so which improves the quality of patient care. So we know that the training and supervision were ranked among the highest priorities during the prioritization exercise with national program and partners. So you also provided the valuable insight on deep dive analysis into the health worker training and the Vivax working group experience and plan to increase the quality of the health worker training. Thank you very much, Dr. Kerry. So let's now proceed with our Q&A session. So I noticed some question in the Q&A box. So the question from Dr. Prudence are already answered. So I would like to go to Jocelyn Yukon. Hello, Jos. Would you like to ask question directly to our speaker, or should I read for you?
Hi, Dr. Bond and everyone. Thanks so much. I'm happy to state it out for the group. My question, Carrie, well, first, thank you. That's an excellent summary of the challenges and some of the gaps. And it's wonderful to hear about the progress that the working group has made since our last meeting in terms of developing some of these more interactive and I presume consistent with adult learning theory approaches to strengthening Vivax training. That's all really exciting. I had two suggestions for the group to consider. One is just thinking about shifting from a training focus to a quality improvement focus, which is something that has become the norm in the health sector more broadly, consistent with provider behavior change principles and the recognition and the fact that no matter how good our trainings and retrainings are, a more continuous approach to quality improvement is often more impactful. And then the second suggestion is whether the working group is looking at whether and how to help national malaria programs use mobile or digital tools for some of the quality improvement objectives. I just, I think we all need to be cautious and pragmatic. I hear, the dream is that we would have fantastic trainers who are trained to be good communicators and facilitators. That isn't always possible at all levels of the health system. And I think, there are also time and cost considerations to achieving all of our quality improvement objectives with what tend to be, at least for the moment, primarily offline trainings. So those are two thoughts, and looking forward to learning more. Thanks.
Thanks. Should I answer that now, Dr. Bone?
Yes,
Yeah.
yes, okay.
Okay, thanks a million, Joss. Yeah, you're absolutely right. We should be talking about quality improvement as opposed to training. I will say it's, I tried to allude to it previously. There is a mindset shift required to elevate training and to get to that point where we're talking about quality improvement. But I absolutely agree that's where we should be. That's what we should be talking about. In terms of the more continuous quality improvement approach, also agree, as you saw, effective supervision was also ranked quite highly by national programs and partners in terms of just achieving malaria elimination. I think there is very much an understanding that there needs to be a follow-up after training and prudence. I see your question about supervision as well. I think at this stage, we're just focusing on the first step of that. But, when I talked about the post-training competency testing, part of that analysis is, okay, who's fallen down so low that they need retraining? How can we target, and this goes to, I think, a PSI, the Hunky system, where you target your supervision to the lower performance and higher caseload facilities, perhaps. I think in the working group work last year as well, our experience through COVID has been virtual, but also I think our skills to do videos and video calls, but also YouTube stock videos of how to do various things has improved too. And that was one of the suggestions as well for more, as you're suggesting, just more mobile or digital methods for quality improvement and follow-up. I think we'll have to start refocusing on that a bit next year as well in terms of the effective supervision.
Thank you very much, Dr. Kerry, for responding to the question, not only from Dr. Jules, but also from Dr. Prudence. Thank you very much. So 2% are raising hand. Sherry, could you please ask the question to our speaker?
Thank you so much, Dr. Phone. Thanks to all three presenters. My question, I have two questions, and first question to Kerry. I saw on your one of the slides showing NGO and all stakeholders equally prioritizing this training part. And I just wanted to understand how you include those NGOs and some of the key people involved in the community level work to improve Vivax management, but also particularly on G6PD, because now we start seeing that there is a knowledge gap and we need to bridge that gap. So that's one. And maybe I will ask question to Manas. Dr. Manas, very good presentation. Thanks. One presentation shows that CLM, very happy because CSO platform, you will see in my presentation later, we're also planning that. But just wanted to understand if already you have plan and you know where you are doing, so that would be helpful for us to understand and align with what Vivax working group is planning. And one slide was mentioning about the cross learning. So I just wanted to open the opportunities for us to have collaboration, ongoing collaboration, I would say, because we have been working together in the future, where we as a platform can also bring our knowledge from the partner and also learn from MMB working group partner over. Thank you.
Yeah, who will answer first? Dr. Gary?
Great. Okay. Thank you.
Okay.
Thanks, Milin Shri. So the CSO, yeah, I mean, you guys were involved in the prioritization exercise, so you understand how we came up with those figures. I think in terms of involving the CSOs, I think maybe it's a good example of what we're trying to do here in Thailand. So we're working with World Vision and CSO platform to bolster what's happening in the areas where tafenoquine will be rolled out by the DVBD in the next few months. And by bolstering, what I mean is to increase the awareness among Vivax patients of the necessity of G6PD testing, to then help follow up patients in terms of adverse events, and to reiterate the need for adherence to Primaquine, because obviously Primaquine still stays in the toolbox for Vivax elimination. So that's one example of how we're working with the CSOs at the moment. I think we'd like to do more of that. Certainly we're interested in improving quality, going back to Joss's point on quality improvement. I think using something like community-led monitoring could help us do that from, pulling from the community side to increase that quality. So yeah, I think we're open to definitely more collaboration and talking more about how we could bring CSOs more into that training. I think the last thing I'll say is, at the moment, the training package is very much targeted at what I'll call the formal health sector. And that's because we have to start somewhere. But what we would love to do is have a bolt-on module, which is where the community, there's more community pieces to that, and that could integrate, the tool that you guys have developed on adherence as well for Vivax Radical Cure as well. I'll stop there. Thank you.
Thank you, Dr. Carey. And thank you, Sri, for that question. In fact, I would like to say that we want to learn from CSOs as to how to promote community-led monitoring and other perspectives in the training as such. And in fact, build on our ongoing collaboration to have you as a big part of our team, as to know not only what the community needs and how, let's say for the G6PD training, what healthcare workers need, what the community perspectives are, maybe also enhanced patient adherence if that's needed there. So there are different ways that CSOs will definitely play a big part in our work plan as we envision that. And I just want to thank you for the ongoing collaboration, and we hope to learn more from you.
Thank you very much. So I saw some question in the chat box and Q&A box. Because of the limited time, I would like to allow Dr. Muhammad Rahman. So could you please ask the question?
Yeah. Do I am audible?
Yes, we can hear you.
Okay. Thank you, Caroline, for your action-oriented presentation. And I just jumped to the question that how can, as you know, we were in the paradigm of falciparum, so that Vivax is not prioritized, and our training curriculum, training guideline, all are customized, focusing on and our trainer mindset also. Those who are clinician are falciparum focused. But in the recent couple of years, we are observing that epidemiological shift, that earlier falciparum was 80%, now it is going down to 60%, and Vivax was earlier 20%, now Vivax becoming 45% in recent years. So we need to reorganize, develop SOP, also rewrite our national regiment also, and include G6PD as in point of care. So for all this, how could Vivax group can support our national program from onward? This is my question actually.
Yeah, that's great. It's great to see that you're seeing that pivot. So your falciparum cases are coming down, obviously. I imagine because you're doing a very good job. We would be delighted to help support. First, I think maybe we should set up a phone call separately, and we can discuss how we can support, get some of the training materials over. I think what also might be very useful is to talk to some of the other programs in the region who have experience in implementing the G6PD as well. They have some great insights as to both the challenges and the enablers that allow them to implement G6PD. So yeah, let's set up a phone call and begin those discussions so we can support you to do that.
Thank you. Thank you.
So thank you very much, our speaker, for your excellent presentation and participants who involved in the session. So I would like to hand over to the chair of Vivax Working Group, Dr. Nina, to moderate the last session. So over to you, Dr. Nina.
Thank you, Dr. Vaughn. And we'll straight away move to the next session so that we save time for discussion at the end of that session. So this session deals with health systems impacting malaria, and we have first presentation on pooled procurement mechanisms from Dr. Sunil Garg. And Dr. Sunil manages the Global Fund Pooled Procurement Mechanism, PPM operations. With a tenure since 2008, he has collaborated in multiple PPM countries in both Asia and Africa over the last 15 years. Before joining Global Fund, he worked at Ministry of Health in India. Over to you, Dr. Sunil.
Good morning, good afternoon, everybody. Let me share my slides first, and then struggling to find the share button. Do I have the rights to share?
Yes, you do.
And shall we share from our side?
Yes, I was expecting, because I shared it earlier, I thought I can't find this. Yes. Perfect. Thank you so much. Sorry for that. Let's quickly look at what is PPM, and then let's go to next slide, please, or I take control. Yes, thank you. So I will just not talk about Global Fund. I assume you know about Global Fund. We have a supply operation department in the Global Fund, and the main focus of this department is to strategically implement the procurement and do the sourcing activity, manage the quality assurance in-country supply chain operations. We provide HTM products, HIV/TB malaria products, and also use PPM as a tool to do the procurements and ship the goods to the countries. If we go to the next slide, next slide, please. Yes, thank you. So this is a snapshot of our journey, and we are going to new strategy now, starting from 23. But if you see on the right-hand side, Global Fund started in 2002, and in 2007, our board initiated market shaping strategy, which had two components. One was pool procurement mechanism, and second one was PQR, price and quality reporting. So we started from there as a Global Fund doing procurement for the countries, because the biggest challenge with the countries was that they were not able to procure on time, and the programs were failing because of that. And also we had some challenges around quality assured products. So for first few years, we were doing a reasonable amount of procurement in the range of 300-400 million worth a procurement of HIV and malaria products. And from 2012, we started doing framework agreement with manufacturers, because we had enough volumes to pool and have a better negotiation with suppliers. So we took over in-house framework agreement negotiations with the suppliers, and we started seeing good results of better prices, better qualities, and then terms and conditions, etc. So we had several steps in this journey. So the first of the step was that we went into market with big LLIN framework agreement, which was a big tender at that time, and then followed by ARVs and ACTs after that. And during that conversation, we also started feeling there's a need of automation of this, because operations become heavy. So you need to have some automation so that users can easily place orders and to get products on time. So we launched Wambo in 2016, which is our platform to do the procurement, where all the procurement principal recipients can go to the Wambo and place requisitions, and we link it with our framework agreements, and our procurement as service agents do the logistics part and deliver the product. So now we are in around 2020. We were doing up to that time, we were, let's say around 2020, we were doing around 1.2 billion worth procurement every year. And with the COVID, the volume doubled up. Because of the COVID procurements, we reached around $2 billion worth procurement every year. And we had a steep learning curve during, and also we found some good opportunities that how we can do even better. So we launched new market shaping strategy in 2023. The center of this strategy is that equitable access to quality assured health products. And that's the key for us to make sure, irrespective of the funding source, we are open now to not only global fund funding, but we are also open to work with other partners and recipients, whoever want to procure through our framework agreement products. So we are going to execute this procurement strategy in coming months, and we are working on many other new innovative things under that. Let's go to the next slide, please. Yes, so this is a snapshot of our achievement, and it's an example of last year, where we have what we call is OTIF, on time in full, where we are reaching around 85 to 95% range, where our delivery times are. Generally, we take maximum, depending on the product category and the type of product, between 3 to 9 months is our lead time from requisition to delivery. We are able to, and also, of course, depends on the volume, etc. We are very much responsive to emergencies. If there are any stockouts or any emergency, we are able to deliver in few weeks' time. And also the prices have gone down significantly in most of the product categories. If we talk about example, 10 years back, malaria RDT would cost $1. Now it's like 25 cents or 30 cents. Or you talk about HIV treatments. When we started, it was like $200, $300 per patient per year. Now we are at less than $50 per patient per year. So we have made huge progress, not squeezing the profit of suppliers, but also enabling them, giving them enough visibility, working with them together to do the innovation and reduce the production costs, etc. So that, you know, when we go to market, it's a sustainable market. We are not pushing other suppliers out of the business. So we keep healthy number of suppliers in the market. We also work with them to give them good visibility on the demand side so that they can work optimally. And this is a snapshot of our procurement. Last year, we did $1.75 billion for procurement and around 5,600 shipments to 83 countries. And most of the products you see in the graph that we have been procuring bed nets, roughly 100 plus million bed nets we procure every year. And then ARVs, and then of course, still we were procuring COVID-related products, which was around 18% of our spend. And across the other product categories, ACTs has been consistent, and we have been procuring more or less similar volume. And also we procure little bit volume of non-health products like vehicles and other things. On the right-hand side, we have a mechanism to trace the on-shelf availability. So we have done some work on assessing what is the impact on the ground, whether the products are really reaching at the last customer or not. So we have seen a good improvement in previous years. I mean, to be honestly, we haven't seen many stockouts in recent years because we have been working with countries regularly and ensuring the supplies are smooth and uninterrupted. Next slide, please. Yes, this is again the snapshot of the countries where we work. So if you see, mainly we work in the Sub-Saharan Africa, where our maximum products reach. And also we have work in Asia and Latin American countries. Most of the shipment we do by ocean because we try to optimize the freight and other costs, logistic costs, and also due to environmental reasons. Our maximum shipments are by ocean or rail or road. Rest of it is because if it is a small volume consignment, it has to go by air, it will go by air. Wambo user satisfaction has been very good so far. We have 90% plus user satisfaction. It's very simple ordering a platform where people can just enter into system, find their product, put into their basket, and place their acquisition. And there is a approval process. After that, it goes through different approval stages and it becomes a purchase order. Next screen, please. This is a very simplistic view of looking at how we work with the whole system. The Global Fund Supply Operation Department is sort of coordinating the procurements between manufacturer, recipients, and the procurement through our procurement service agents. We have our framework agreement for key health product categories, which is ARVs, ACTs, bed nets, and RDTs. There are other tail end products which we do not have framework agreement because we do not have leverage in the market, and it makes no sense to have framework agreement for those small volume.
I know. Ah.
Sorry. Okay, so then we have a framework agreement with manufacturers. When we receive a requisition, we allocate a manufacturer and we pass it on to our procurement agent who arranges logistics and make sure they deliver in country wherever it's need to be delivered. And other end, if it is a non-framework agreement product, they will do the procurement process for that. And we will still monitor the quality of procurement. So this is a simplistic view how we coordinate through our procurement agents. We have different procurement agents for different product categories. For example, for non-health products, we work with like vehicles and computers, etc. We work with UNOPS, who does the non-health products procurement. For condoms, we work with UNFPA. They procure for condoms and lubricants, etc. Through UNFPA. And other procurement agents are for bed nets and ARVs and ACTs and RDTs. We have separate procurement agents. We follow the Global Fund's quality assurance standards, which means we prefer WHO pre-qualified products or SRA products. And also we ensure that if there are certain needs of the product, we have a system called ERP, where we have some special provision to procure difficult to solve or difficultly with the products which are not easily available, to get those products with special quality assurance means, so we can get those products as well. Next slide, please. This is the process, a flow chart, how the system works in Wambo. The Global Fund country team and the principal recipient agrees on what and the grant, what they need to procure. They go to Wambo platform, they submit their requisition. The PPM sourcing team will allocate the suppliers, and the procurement order will pass on to procurement agent, and it will go to procurement agent will issue a purchase order to manufacturer. And then the PSAs, procurement service agents, freight and logistic provider will pick up those goods and deliver to the countries. And during the whole process, we monitor everything through our KPIs. So every performance of supplier or procurement agent or freight and logistic provider is monitored by us. Next slide, please. And this is a snapshot of non-global fund funded procurement. We do not have as much procurement from non-global fund sources yet, but we have been supporting some of the countries where they have, or the partners who want us to procure products because we have an established system. So primarily we have been supporting countries for ARVs and some of the miscellaneous products, bed nets, and HIV RDTs. This has been the key categories where we have supported some of the countries. If you see on the right-hand side corner, some of the countries have been procuring through us with their own monies or money coming from, for example, UNITAID for rifampicin. So we have been supporting countries in these activities. It's the challenge with these procurements is that generally, because it's a government or non-global funded procurement, we ask for advance payment, and that becomes a little bit hurdle into this conversation. But we are still exploring other possibilities if we can solve that issue of not requiring advance payment. But that has been a bit of challenge. That's why we couldn't get enough volume under non-global fund funded procurements. Yeah. Next slide, please. Like I mentioned, we monitor the performance throughout the procurement cycle. It is performance-based allocation to the suppliers. We do 3 years procurement cycle with framework agreements, and we allocate annual volumes to the suppliers based on their performance and price. Of course, price is the criteria, but past performance is even more important. For example, we have conversation with suppliers on a quarterly basis to look at their performance. And if one supplier is doing well, other is not, we reduce or increase volumes accordingly. So that's the biggest motivation for any supplier to deliver it on time. So when we have the requisition management, we have our internal KPIs where we look at how long we take to process an order, also production to shipment, whether the supplier has delivered on time, or when it after picking up, whether it arrived at that time or not. So all the steps in the procurement process are monitored regularly, and also the performance feedback is provided to each stakeholder. And it has implications. If somebody is not performing well, they have the consequences. And it's done on a quarterly basis and very stringently. So overall, this works very well. We have a huge learning curve here. We are improvising when we see some challenges, especially during COVID. We met a lot of freight and logistics related challenges or warehousing in-country logistics challenges. But we learned a lot, and I think we are building on those and in the next market shipping strategy. I think that's the last slide. Yes, thank you.
Thank you, Dr. Garg, for this excellent presentation. And, I have been part of ministries and I understand how difficult is the procurement, because guidance and training and other things may be provided, but unless the programs or at any organization has a quality product, those things cannot be executed. And it's really nice to see that, which you explained, that the platform is being used for full procurement, and also you are supporting non-global fund countries as well, because even when it is a small procurement, like in WHO, we were studying countries which are very near elimination, have very few cases. For them, small quantities of procurement becomes a challenge. So we will take questions at the end of the all presentations. And yeah, thank you once again for this very elaborated presentation. Thank you. Okay, so we now move to next presentation. So I don't think we have Dr. Rinku Sharma with us, and we have no prior intimation. So we'll move to Dr. Acharya for presentation on community-led initiatives for Vivax malaria. Dr. Srihari Acharya is a project manager at Allied based in Thailand, and he manages the malaria CSO platform in the GMS, that is Thailand, Myanmar, Cambodia, Laos, and Vietnam, under the Global Fund RAI grant. Over to you, Dr. Acharya.
Thank you so much, Dr. Nina. It's my pleasure today to share some of initiative with regards to community-led initiative. Just to correct, I'm just a public health professional and working now with the malaria CSO platform. Just want to check if my presentation is okay to move now. Can you see my presentation?
Yes, it looks fine.
Okay, great. So those don't know the CSO platform, this is a network of communities and civil society organization working in malaria, is serving at-risk population in the Mekong region. This platform is funded by Global Fund RAI grant. It was established in 2014 to serve cross-border initiative and some of the border population, and now we have expanded our network to over 60 NGOs, CBOs, and community network within the Mekong region and outside. CSO platform from border focus to now shifted to little bit wider with knowledge sharing, capacity strengthening, and advocacy. We, as we said, is funded by Global Fund. Global Fund funding is going to continue for next round of RAI grant for the platform. And the Vivax management and POR of malaria is one of the major focus of the platform when we start working with Global Fund funded and non-Global Fund funded NGO partner for next 3 years. Overall, platform also now moving from malaria focus to a little bit broader area, which is relevant to our partners' work and also some relevant to community health worker in the region. So I think the earlier Dr. Rahman mentioned that we are moving now from doing better in falciparum management and still having challenges in Vivax. And I like his comments, we need to reorganize our focus and tools that we designed earlier. So in Mekong 5 countries, just to give you example, there are more than 30,000 village malaria workers working in malaria response, and these numbers are only coming from the Global Fund funded, and there are many more from other initiatives. And then if we see the overall regional epidemiological situation now, the falciparum has gone down. I think we are doing good, except in some areas, but the Vivax remain challenging, and that based on community perspective and the NGOs that we work is because of increased mobility nature of risk populations work, because it's still large number of people are relying on forest product. We don't have clear evidence now, but also there are some comment coming in. It's also because of the climate change, because vector is showing resistance and increased cross-border migration because of political situation in the neighboring countries. Communities working in malaria project are actually to extend the hand of the national malaria program, because you see, in all, I give you example in the Mekong country, all 5 countries, national malaria program has established volunteer or the community-based network, and then NGO are supporting national malaria program to provide capacity and mobilize those network to provide services. So they are serving literally as the extended hand of the national malaria program, local authorities at the provincial level, bringing services closer to the communities. This is just to give you example what in general our partner are doing, or the network are doing in all 5 countries. The community health worker and NGO partner they are supporting in screening or testing using RDT. There are a couple of challenges in some countries because of the legal barrier, but they are adjusting with the what they can do with the situation and the following local authorities' guidance in terms of how they can provide support to them. Those community health worker and NGO staff on the ground are also providing awareness raising and some of the preventive activities, including LLIN distribution. That includes, if you see the photo on the right bottom, that's literally taken inside the forest in one of these 5 countries where a large number of forest workers were working, and community health workers, they were reaching out inside the forest, providing LLI and testing malaria among those risk population, and bringing them to the nearest health facility for confirmatory test and the treatment if they are positive. The community health worker on the ground, they're also working for the referrals. It depends on the country and the financial resources. Either they do assisted referral or not. I give you example in Thailand. Under this RAI 3 grant, many NGO volunteers are doing assisted referral in an area where they don't have authorization or the facility nearby. So particularly is in the migrant community in Thailand, these NGO volunteer, they can't do RDT tests because of the legal barrier, but they have very good collaboration with the local authorities where they can do referral and then provide service to those risk population. And the very important work community health workers are doing in many of these countries, monitoring treatment compliance, because it was very low and now is coming, is showing good results. So in treatment adherence is increasing, and I can take a couple of countries example. For example, Laos is now doing almost nearly 100% under the CSOs or their volunteer area, and then same happening in some of area in Thailand. This is what platform is doing to support those initiatives which I presented earlier, and support those community health worker network and NGO. CSO platform work in collaboration with multiple other partners, including Vivax working group. Thanks for the support to the working group. We designed one Vivax Radical Cure Counseling guide. This is a regional guide we finalize, and which is ready-made, which our partner can tailor to their country policy and the guideline. So this allow we have all this guideline and focus on the what are the concern and the frequently asked question from the community health worker, and also about the radical cure treatment adherence, and then motivating those community health worker and the some of the patient to monitor the side effect. These tools is available on our website. Some of the countries now they starting to translate this tool into their national language, aligning with the guideline and policy, this is just the additional reference, not to replace any existing tool in available in the country, either developed by other partner or the National Malaria Program. This is another example of the platform initiative. We provided training in partnership with WHO and UNOPS, bringing all NGOs from Mekong countries, who is working in the data and monitoring and using those data for their program designing, which helping them to make decision where to focus and where to shift their program focus. This training allow participants to familiarize the WHO database, regional database, and utilize those information in program designing. We also develop integrated disease handbook for the community health worker, which gives basic understanding and knowledge on multiple disease, which is relevant to community need. Those diseases were prioritized based on the need assessment and priority given by countries. As we now start hearing that malaria-only services in the community is not well accepted by the community, because this is compared to other health needs, malaria is in least priority unless they get to the severe situation. So community are expecting NGO or the community health worker to go with the package of services, at least who they can help with the fever management or other common health issues. So to start with giving some basic knowledge, we produce this handbook, which is translated into 4 languages. This is what I mentioned in my earlier comment about the community-led monitoring. This initiative we are piloting in Mekong region because this has never been implemented in low malaria endemic setting. There is already CLM guide existing for high endemic setting, and there are a couple of examples coming in. So we are building from that learning coming from high burden countries, and then starting with the development of CLM guides for low malaria setting. This CLM will focus on the putting community at the center, and making them able to collect data and analyze those data for improved services, which we hope that leads to the adjusting the policy that communities see favorable and useful for them. This is also because now we are in the Mekong region, malaria is going down. We are doing good and reaching towards malaria elimination, but the prevention of reestablishment is now biggest concern. So the CLM, we are putting this POR also as part of the CLM scope. So if there is no funding, donor funding available in the region, those community will be able to work with the local authority, monitor the situation, and respond to the situation. So we are piloting this from next year. We are piloting in 1 country. We haven't finalized which country because we still are negotiating with the program designing, but I think starting will be going with designing of the guideline and implementing in 1 country. This is another initiative which is supported by MMB. MMB is supporting platform to implement community G6PD testing awareness raising project. It's a small project we are piloting in one of the border provinces in Thailand. This project is focusing on improving understanding of the G6PD and encouraging community to go for the G6PD testing, and also prepare community health worker in the area to monitor adverse event. Carrie mentioned in her presentation that Thailand now rolling out this TQ and starting building capacity, which I think we saw some of those in Carrie's message as well. So with this project, we are helping National Malaria Program to bring more people for testing. And this is, as I said, is on the Thai-Myanmar border, where we now recently seeing very high malaria cases because of the high mobility on the border. So this is our future focus, as I mentioned, in the RIFOE, which will start from 2024. But we started this activity, learning opportunity, knowledge sharing opportunity from Thailand to Cambodia. You will see some familiar faces. We facilitate POR workshop and the learning visit to CNM from Cambodia and the NGOs who is helping CNM in Cambodia to learn from Thailand. So Thailand NMP provided, share their practice, and then some of the strategy they have been applying in POR in Thailand. So this will continue in RIFOE, but this is just wanted to show that one of the initiative platform is now focusing, linking with the Vivax response in the NECO. So that's all for my side. Thank you so much.
Thank you, Dr. Acharya, for highlighting the community-led initiatives. You know, in any program, I think the activities at community level is the backbone. And in different, as you said, I mean, you described about GMS, but in different countries, different activities are being done, and in many, you know, diagnosis as well as treatment, they are empowered to do treatment as well, because you know these cases are found in difficult to access areas, and that has really highlighted the benefits. We could not have a presentation from India, but there are many scenarios where we find, and many these be given some incentives also to follow up and monitor, and they help in the monitoring any adverse effects. So this is a very important component, and as I mentioned earlier, we will take questions at the end of the session. And thank you very much once again. So now we move to the next presentation on importance of integrating vigilance systems in public health programs, including malaria, which will be presented by Dr. Noha Lesa from WHO. And Dr. Noha is a clinical pharmacist by training who started her career working in hospitals in UK, including hospital on tropical diseases, and where she worked for 10 or more than 10 years. Then she has done a lot of studies in pharmacovigilance and pharmacoepidemiology, with focus on the safety of medicines in children and during pregnancy, before, of course, joining the WHO pharmacovigilance team in 2015. And part of her work involves working with disease programs to integrate pharmacovigilance. So over to you, Dr. Noha. Dr. Noha, we can't hear you. Can you unmute your mic?
Hello.
Yes.
Good morning, good afternoon, good evening. It's a pleasure to see you all today, and thank you very much for inviting me. I'm just get the screen ready. Okay, I think this is the correct screen. Have I got the correct screen that you can see?
No, we can't at the moment. Dr.
You
Phone,
can't see
can you
anything?
help us?
You cannot see my slides?
Now it's coming up.
Okay.
Yeah, it's there.
Okay.
Fine.
Excellent. Okay, so thank you very much for inviting me, and it's a pleasure to be here. So basically what I will discuss today is, first of all, just a background to what is pharmacovigilance, and why we want to integrate pharmacovigilance in disease programs, and how to integrate pharmacovigilance in public health or disease programs, and what methods are available in pharmacovigilance that we often use in pharmacovigilance in public health programs. So just quickly, what the definition of pharmacovigilance is: it's the science and activities related to the detection, assessment, understanding, prevention, of adverse effects or any other medicine related problem. And so with this, the scope is quite wide. It also includes medication errors as well as adverse drug reactions, and it incorporates a whole range of activities as listed below. So how did we come about pharmacovigilance? How did the program of pharmacovigilance, which is known as the WHO Program of International Drug Monitoring, occur?
Excuse me, Dr. Noha.
Yes.
We are sharing the slide from our side. So could you please share the next or something so we know?
Oh, okay. You're not okay. So I will. I'm not sharing it. Okay.
Yes, please.
All right. So sorry. Can you change the slide? I was looking at mine. Sorry. Next slide. Okay. Thank you. Okay. So how did we have pharmacovigilance at WHO? How was it established? And what led to the whole program, and where can you see the program being active? So WHO, the pharmacovigilance program is the WHO Program of International Drug Monitoring, and I don't know where everyone is, but in the 1950s to 1960s, there was a drug called thalidomide that was given to pregnant women for morning sickness. And people weren't aware of its safety then. And there were a lot of children that were born to women who were exposed to this drug with major malformations in their limbs. And then once this was discovered, it was 2 and 2 were put together, and they realized that it was because of this drug. And there was it was a disaster because there were hundreds and thousands of children born with these malformations because the mother took this drug. And there was a World Health Assembly resolution. And so in this resolution, at that time, there were 10 member states who had got together, and they invited other member states to arrange for a systematic collection of information on serious adverse drug reactions observed during the development of the drug, in particular after its general use. So basically calling for the post-market surveillance of medicine. So looking at the safety of medicines after it's been developed and released into the public. And so it started off with 10 countries. And if we go to the next slide. Now you can see there are over 150 countries who are part of this program. So what we mean by this, that when they're part of the program, they have a pharmacovigilance focal point in the country, they have a pharmacovigilance center in the country, so they have the start of a pharmacovigilance system, but they do vary in their maturity. So some countries will be much more mature and advanced in the way that they collect and what they do, data, and what they do with the data than others. And I have another slide, which is not, next slide, please. I think this is the next slide. Okay, so the slide is missing, but I will just maybe say that I had looked at specifically at the Asia-Pacific Malaria Elimination Network, the countries, and out of all the countries there, 17 are full members of the program. So 17 have a pharmacovigilance focal point that is reporting to WHO, and I'll explain how they report to WHO. And 2 of them are associate members, so they have a focal point. They're part of the program, but they're not yet reporting, and 3 are non-members. And out of those countries, 5 countries have been, WHO have now just, I mean, it's one thing to have to be a member. It's another thing to have a functional and mature advanced system. And WHO is now they have something called a global benchmarking tool, which benchmarks regulatory agencies, and regulatory agencies are mainly where the pharmacovigilance systems sit. Sometimes they don't, sometimes they sit within a university, but majority are in a regulatory agency. And this is actually a good thing, because by strengthening, the countries have an urge to strengthen the regulatory, there's a big push to strengthen the regulatory systems, and with that comes the pharmacovigilance. And out of those countries, out of the Asia-Pacific Malaria Elimination Networks, 5 of them have a high maturity level an advanced pharmacovigilance system. And so just to maybe explain how it works. So within a country, we say, yes, we have pharmacovigilance focal points, we have systems in the countries, but how does it work? So what happens is usually you have an adverse drug reaction, it's reported. It could be reported via a healthcare professional, it could be reported in some countries through patients. And then it will go to the pharmacovigilance center where it will be coded and be put into a system and shared in a global database. And the reason for sharing it with a global database is that you pull the data, and when you pull the data, it's more you can rapidly find any patterns that are that occur more than you would expect and signal a certain adverse drug reaction that you need to look into or is of concern. And currently there are 36 million reports in the database. 100,000 of them are for anti-malaria medicines, and 1,000 of them are for malaria vaccine. Moving on to the next slide, please. Okay. So why do we want to integrate? Why do we want to combine pharmacovigilance and disease programs such as malaria? Well, I mean, as you know, as time is going and we're focusing more on elimination of certain diseases or more control of the diseases, new products are becoming more available. A lot of them are being available and in an accelerated or facilitated pathway where they are available more quickly, more rapidly, due to many mechanisms such as more donors providing help to aid to get the product through, a larger scale, things being scaled up largely, and regulatory pathways that allow the medicines to be licensed earlier than what would usually take, but they often have conditions, and such conditions may be that you need to have a robust pharmacovigilance system in place to be able to provide that. So it's a way of having pharmacovigilance, it's a way of accessing the medicine and having it more available to people to use. Next slide, please. And just to repeat, now in the future, lots of products are on the pipeline, and many of them will be licensed in the future, coming up soon, in settings. And many of the settings, yes, although they have a pharmacovigilance focal point or system in place, they don't have such an advanced system, and there needs to be an improvement or strengthening of the pharmacovigilance system in these places. So by and then it's not just also new medicines, there are also older medicines that may be repositioned or repurposed or given to a different type of population or a different patient group that will require more intensive vigilance or intensive monitoring of their safety. Next slide. So these are just some examples of situations where there have been recommendations for a strengthened pharmacovigilance system in guidelines for some disease programs. For example, seasonal malaria hemoprevention. In the WHO guidelines, it had stated or recommended that pharmacovigilance should be strengthened where it exists, and it should be instituted where it does not. Another would be the introduction of bedaquiline in tuberculosis that had called for spontaneous reporting, and that also had another form of methodology that we use in pharmacovigilance, active pharmacovigilance, where you're looking at things more intensively. And more recently, with WHO therapeutic guideline for COVID-19, the introduction of a new medicine, molnupiravir, a therapeutic for COVID-19, it had a recommendation that it should be given in countries where there is a pharmacovigilance system or program in place. So next slide, please. So what does the Pharmacovigilance Center have to offer to the public health program, and vice versa? What do the public health programs offer to the PV centers? So the pharmacovigilance or the PV centers, they have the expertise, they have the tools to be able to collect the data and evaluate the data. And what's more important is their independence. And with public health programs, they aim to eliminate. And when something appears to maybe compromise the program, such as the possibility of a safety concern, then there tends to be a little bit of a conflict of interest. Even though necessarily by identifying them and managing such adverse drug reactions can actually increase rather than compromise the program. So the Pharmacovigilance Center offers an independent overview. They have the spontaneous reporting system, which I had just described, where you have a report and it goes to the Pharmacovigilance Center, and then it's pulled into a bigger database. The public health programs generally have a little bit more money than the pharmacovigilance center, so that's our pharmacovigilance interest with the public health programs. And also, they offer a cohort of patients. So generally, when you're looking at spontaneous reporting, you don't know what the denominator is. You don't know how many people are exposed to a particular medicine or treatment. But with public health programs, sometimes, when you're distributing the medicines, you have an idea of how many patients are exposed to the medicines, which then you can have a rate, which you can't generally have with spontaneous reporting, because it's basically it depends on voluntary response reporting. So the numerator doesn't mean that the number of reports means that that's the total number of people who have actually received, who have actually experienced an adverse drug reaction. There could be more, and it's underreported. It's not completely accurate, nor is the denominator. So for us, having a public health program collaboration, you can have more idea of the number of people exposed. Next slide, please. So, why to integrate then? I mean, through integration, we've seen in the past, it promotes public health confidence and compliance. We've seen situations where there's mass drug administration of a medicine, and a pharmacovigilance person is actually there at the site during the campaign, and that increases the public trust and therefore increased compliance. There have been it strengthens for us, it strengthens pharmacovigilance systems, it strengthens our systems. It helps when you do have a crisis, or when you do have a situation, by combining forces, you're able to respond and communicate effectively in such a crisis to damage control and to not, so you wouldn't have any compromises to the program. And you're able to use all medicines in different populations and combinations and indications. And there are several other reasons, but these are some of the reasons. If we can maybe move to the next slide. So how do we integrate? So how do we actually do this? I mean, generally, when you look into most countries, there is the public health programs and the pharmacovigilance programs are very vertical. They don't really work together. So how do we work together? And one thing, one problem that we have seen in the past, which is very difficult, is that the public health program will start to collect data. And so you have two pockets of people having data. And some of that data is duplicate, some of that is just not shared. So then you have the data in different areas, and no set of data is complete. So how do we go about integrating it? What do we do? Generally, what you could do is, look at what we've done in the past is we look at PB systems. We've done a general baseline assessment of them and seeing whether they do integrate with the system, with the public health programs, and what gaps that we can do to help identify gaps that we can help take measures so that they can start to integrate. We need to ensure that the national guidelines and SOPs for disease programs has a component of PV in it. The disease programs should invite PV people to their meetings, and vice versa. And we've done that in the past. I think even seasonal malaria chemoprevention, when it was being in preparation for its being rolled out, we had brought together the disease programs and the PV focal points, and we did trainings with them together, and they sat down and they had a plan together to monitor the safety of these medicines. So also the training. So usually, sometimes in public health programs, you have cascade training, and it goes down from one level to another, down to the healthcare provider, the healthcare worker, and to incorporate PV needs to be incorporated into the training. It's a small module. It depends on how long the training is, and each stage of the training will have various versions of PV in it. Another big thing is to adopt IT solutions to promote data sharing. That's something that WHO program can really help with, because we've really developed on that. We have within the program that I've showed you, we provide countries with data management systems. We provide countries with tools to be able to collect data through the mobile electronic tools, and we help them to do their data collection forms. So we help. We have these tools in place, and one thing that we've noticed, and one thing that we've noticed as a barrier to integration, was that health or disease programs or public health programs, they don't want to share the data that they collect. There is a resistance to do that. And so what one way that we've tried to overcome this is by having systems in place that we can share our data with them. So their data, it's a long process, but their data will be able to see part of the big database that I've showed you, but only to the extent of, say, example, the medicines related to that program. For example, in vaccines and the EPI programs, they'll be able to see reports related to the EPIs and not the whole database. So there have been solutions being put into place to help bridge that gap, because I think this is a major problem or a major barrier for integrating pharmacovigilance with public health programs. Another thing is, when you have advisory groups and advisory committee groups, is to have both people in place, to have a PV and a public health program, someone from the public health program in the advisory and risk assessments, and also to engage in the most appropriate methodology. And then maybe go through, if I have time, to go through some of the methodologies. Next slide. Okay, so I described earlier when I showed you the map and the way that you report, the spontaneous reporting, but there are other methods that we use with public health programs that may be more suited for the public health one. So when you have something that's new, you want to monitor it more intensely. And so we have some methods, for example, cohort event monitoring, where you would follow up a patient for a period of time, and this is more to characterize the treatment and to have more information about the treatment. So you have more than beyond than what's just given out in the clinical trials. So we collaborated with disease programs, and we've developed certain tools, which I will go on to, I think, in the next slide, to show that we have protocols on how to do these studies. Yeah, so we have developed protocols on how to do active surveillance studies. They're all in our website. So there's cohort event monitoring, there's sentinel site surveillance when you have a particular adverse drug reaction that you are worried about and you want to just follow that, or we have a cohort event monitoring where you want to follow up a whole cohort and just to characterize the treatment and the safety of the treatment. Where specific adverse drug reaction in the same way as you would have with the spontaneous reporting, but a little bit more targeted. And we have a handbook that's for pharmacovigilance and malaria at WHO. We also have one for TB, and we have protocols which are there for other medicines, but can be adapted to suit other programs and other questions that you may have in mind. And just the thing is, the different methods have the advantages and disadvantages. Spontaneous is cheap and easy to maintain. The active surveillance is very resource intensive and is really only served for a short period of time. And I think that's it. I think the last slide, the next slide, sorry. Okay. And then, so then you have, this is just a little bit of a diagram of how you have the different methods. So you have, throughout the product life, you'll always do the spontaneous reporting. And the spontaneous reporting is good for very rare adverse drug reactions and for things that develop over time. And you have then the active surveillance, which it's more intensive, and it's usually at the beginning of the launch of a product, so that you characterize the treatment. And then when you make during that lifetime or that product lifetime, there may be some adverse drug reactions that you want to know more about particularly, and that's where you may target it, and you do targeted spontaneous reporting. Next slide. And then this is just a little bit of information of some tools that we have. So just going back to spontaneous reporting, we have at WHO, now we've developed a Vigimobile tool, which will, so it's not just a paper report anymore. We have tools that can be used to collect it online and through mobile apps. And there is a mechanism in which you can share some of the data with the public health program, as well as the National Pharmacovigilance Program, which hopefully then will be, will overcome that barrier that is there. And there are also tools for the active surveillance. So now we've developed also tools to collect cohort, for example, cohort event monitoring, to follow up patients via mobile or electronic tools. And also there's a database that they can manage it with. And then within WHO, we've also, for example, with cohort event monitoring of molnupiravir for COVID-19, we have a situation where we can collect the data and pool it within WHO for a CEM. So these tools are now available, and they're becoming more and more available as things have developed and needed more urgently. And so we're advancing more with these kind of tools that we can offer and countries can use. And I think the last slide I don't want to put up. I cancelled it. Okay, I just want to. No, that's it. Stop. Thank you.
Thank you, Nuha, for that detailed presentation. And this pharmacovigilance is really important. And I'm sure it is being managed through Uppsala Monitoring Center, right?
The Uppsala Monitoring Center is where the database is held. And so the database is held there, they maintain it. But we also have direct access to the data. They also have a routine way of looking at the database to look for signals of interest. But yes, it's maintained there, but it's part of the program. So it's a WHO data, and they are our collaborating centers. So they, as part of they maintain it there. Yes.
Yeah. Thank you. It is so important to integrate with the disease programs, and you very rightly pointed out that we have seen that the pharmacovigilance centers which are mostly located in some departments of hospitals are working in isolation from the programs, and there is no, and most of the reports are generally spontaneous reporting, which may lack in causality, association, and all that. And otherwise, the majority information comes from PSUR or the phase 4 studies of the regulatory trials. So, there's a lot more which can be done. And those initiatives which you have explained are really useful. And especially when we are talking about new medicines and, the medicines which are like Tefnoquine or even Primaquine being used in the country. Many programs say we don't have any problems with even when we do G6PD deficiency, so we don't know how much we know or how much it is being monitored. So all those issues can be taken care of if this integration is possible. Thank you very much for that presentation. So now we can open for question answer session. So before I can please raise your hands if you have a question, although we are approaching 1:30. But Kerry, would you like to ask? You had one question for Dr. Garg, which you were saying you can't put in Q&A.
Yes, thank you. So I think he's just responded actually in the chat. I was asking about the in-country logistics, because actually a lot of the feedback we've had from national programs and stakeholders at country level has been they continue to face stock availability issues. And we can talk maybe more offline about the qualitative feedback on that, but it's to do with coordination, lengthy procurement processes, coordination between different departments, and this is also a pharmacovigilance issue as well, but coordination between different departments from different parts of the ministry. So yeah, I was interested to understand how far down global funds support that, and if what we can do, what can we do about this seeming misalignment in information. You guys have a very strong indicator showing stock availability, but we are hearing reports of something different.
Yeah, I mean, it's a very valid question, because let's say we prefer to deliver up to a center level or regional warehouse level maximum, because that's where we can manage sitting in Geneva. But often countries like Indonesia, they ask us to deliver to thousands of islands, which we do, but not only it's very expensive, often malaria program wants to change the quantities at last minute, which is not possible because you pack them accordingly, and later on changing them at last minute is not possible. That's what most probably leads to that, and that's where it's very difficult for us to manage it centrally, local distribution. So we prefer countries to manage themselves. But the challenge with countries is to doing the procurement of distribution mechanism or arranging that is also a lengthy process. They take months and years to have a contract with somebody who will do the distribution for them. So it's just we need to see what is best we can do, but the quantification or exact quantities which island will get how many is the critical to know upfront. But often it changes. That's the prime reason, especially with Indonesia. Not only the customs clearance and the waivers, and it's quite a intense activity for us. Yeah.
Thank you, Dr. Garg. I don't see any more hands, but yeah, meanwhile, I would like to ask Dr. Acharya. I mean, of course, the trainings are conducted and, some sort of monitoring, but how can, because it's just a routine practice for the countries for training, providing training to community level workers, but what is the quality, and then when do they need retaining, whether it is possible or not within the system which are planned in the programs. So would you like to highlight that part, Dr. Charan?
Thank you so much, Dr. Nina. So as a platform, our training focus on first providing training to those NGO and their staff within the project, and how we decide the training topic. So before we plan with any training, we organize the training need assessment, asking all the partner, what is your need? Like Kerry has highlighted earlier, we do the similar process within the project scope. And based on that, we train to our partners who design the project and who provide support the community health worker, because as a platform from the regional level, it's challenging for us to go down and retain the community health workers capacity. That's something country can do. But what we do, we also ask in that assessment, what capacity our community health worker or those involved in the response need, which is not covered by the country. And if we see that gap, we design those training and we let our country partner to integrate that within the regular implementation.
Thank you, Dr. Acharya. Kerry, you still have your hand raised? Any other questions?
I do, sorry. I've got one question
please.
for Dr. Noha. Thank you so much.
Please go
That
ahead.
was a really useful presentation. I'm keen to know, I know that there's the guidance for pharmacovigilance for antimalarials. Are there any courses available for disease program managers or disease program staff who want to improve their understanding of pharmacovigilance that doesn't go into the in-depth analyses, but allows them to be able to communicate more effectively with their PV units and to coordinate better?
There are various basic pharmacovigilance courses run by our collaborating centers, and in the past we've actually arranged for particular programs have come to us and have asked for training. We've actually arranged for them where we would get this particular program that wants it in a particular region. We'd organize trainings where you would have the managers and the program managers of the disease program and PV put together. But we have general training. There's a lot of vaccine pharmacovigilance stuff that's basic, actually, that's available. But it is maybe something we should extend to have for all other programs. So I'll take that back, that in the WHO courses, but there are a lot of trainings provided by collaborating centers. So for example, the Uppsala Collaborating Center have a lot of training on that. So I can maybe look for a link on there. But thank you for highlighting that, because maybe that's something we can extend what we have for the vaccines to other programs as well.
Yeah, that would be really
We
useful.
have developed in the past, but I think even for example, when there was seasonal malaria chemo prevention, we developed a training pack and a cascade of training, because you have a one level, a high level, then it goes down to a lower, and then the time that you spend training at each level is different, and so you need to make sure you get the key messages and that are tailored to who is receiving the training. So we've done that in the past too. So maybe I can share that with you.
Yeah, that would be really helpful. Thank you.
No, thank you, Kerry, for raising this important point. And I think I have seen that many times in immunization program, this system works very well and reports are received. But in other programs, of course, we can learn from those, and the cross learning can be there. Thank you very much, everyone. And I would like to again thank our speakers for their presentations. Now, may I hand over to Dr. Phone for the poll? Over to you, Dr. Phone.
Yes, I recently launched a poll. So there will be 4 questions. The first 2 questions will be the single response, but the third question will be the multiple response. So I would like to encourage our colleagues to participate in the poll. It will be very useful for us. I noticed that half of the participants already participated. Dr. Nina, may I request 1 or 2 more minutes?
Sure, sure.
So thank you very much. So I will stop that pool. So in like 15 seconds. So we noticed that we got around about 75% of the participants already participated in the poll. So thank you very much. I would like to hand over to Dr. Nina. Thank you.
Thank you, Dr. Phone. I don't think all have participated, but I think this information gives us is always a scope of improvement. So thank you very much for your inputs in the poll. So now we have almost completed our 2-day deliberations, and I would like to now invite Dr. Amita Chebi for closing remarks. Amita is Executive Vice President, Advocacy and Programs for the Asia Pacific Leaders Malaria Alliance and APMEN, and has over 20 years of experience in public health and private sectors across strategy, partnerships, and business development. Over to you, Dr. Amita.
Thank you so much, Dr. Nina. Thank you to you and Carrie for inviting me to close this important meeting. I think it's been an incredible 2 days of engaging discussions and presentations. 2023 has been quite a critical year, and I think in exactly a month's time, when we have the World Malaria Report, which is going to be released with the latest data, we'll have an opportunity to again come together as a group and take stock at how well Asia Pacific is doing towards the 2030 elimination goal. Unfortunately, we already know that the numbers are not going to look great. The malaria situation in Pakistan has been critical due to the floods last year. The Thai-Myanmar border was another flashpoint in the region, and this will have repercussions for the elimination trajectory for the whole region. Indonesia and Papua New Guinea as well, I think, continue to face challenges on their elimination journey. And so against this not very positive backdrop, I think the work of the Vivax working group is more critical than ever. Half the malaria burden in the region is Vivax, and we know that we're not going to get to the 2030 elimination goal without a strong push on Vivax elimination. So the focus of the Vivax working group itself, as everyone knows, has really evolved over the last few years, from building an evidence base for radical cure to now really going further along that continuum and looking at ways in which you can support the catalyzing of policy change for radical cure at the country level, and also ensuring that health systems are ready to incorporate radical cure into their national programs. So yesterday we saw a whole range of new generation malaria control tools that are showing promise, whether it's the sero test, single dose, shorter treatments for Vivax, G6PD diagnostics. And as all these tools become available for implementation, there needs to be an intentional focus on country preparedness for new tool introduction. And I think the Vivax working group under Dr. Nina and Dr. Carey's leadership has really developed an intentional work plan that focuses on support for national malaria programs for radical cure introduction. We've also seen that in addition to large investments for research and development of new tools, there's really a case to be made for catalytic investments at the country level. So looking at the kind of readiness planning support that the Vivax working group provided to Pakistan and Papua New Guinea, there is now an intentional focus within those national malaria programs looking at Vivax in particular. And those are just 2 countries across the region. We need to do more of those. And for that, we do need additional financing and additional investments. And I think the Vivax working group and all its members can play an important role in calling for increased financing for Vivax elimination with key partners like the Global Fund, like the Gates Foundation. So on behalf of APMEN, I'd like to thank MMV for hosting the Vivax working group for the last 3 years. It's been an incredibly productive partnership. And in particular, we're looking forward to the ramp up of activities in 2024, including an in-person annual meeting next year, fingers crossed. So thank you very much. And back to you, Dr. Nina.
No, I just want to thank everyone, the speakers, participants, and of course, our team. Thank you, everyone.
Thank you.
Bye.
Thanks, Amelia. Bye-bye.
Thank you.
Thank you, everyone. Have a great day.